everyone. I'm Dr. Alaa Mosbah, Professor of Obstetrics and Gynecology, Faculty of Medicine, Mansoura University. Today we wanted to discuss the shoulder dystocia. What we wanted to know about shoulder dystocia, the definition, shoulder dystocia, the grades or types of shoulder dystocia, if it is unilateral or bilateral. Also, we wanted to know the risk factors, and we wanted to know how to predict shoulder dystocia, if it could be predicted, and how to manage a case of shoulder dystocia. Of course, shoulder dystocia is one of the most important obstetric emergencies. Okay, let's start with the definition. Shoulder dystocia means what? Shoulder dystocia means delivery of the head associated with difficulty in delivery of the shoulder, which needs certain maneuver to be delivered. The head emerge through the introitus, then retract to the perineum. So we call it turtle sign. I cannot see the neck of the baby because the head is retracted over the perineum like that. Okay? So this is called turtle sign. This is as regard definition. What about the types? Maybe unilateral, if the shoulder dystocia occurs with the anterior shoulder only, overriding is the symphysis, or widget behind is the symphysis here, or overriding is the symphysis. So the shoulder cannot descend down through the pelvis. Or bilateral, both shoulder above the pelvic brim. This is the pelvic brim, as we know. This is the pelvic brim, the inlet of the pelvis. The shoulder cannot pass through the pelvic brim in the end of the pelvis towards the cavity. If it is both shoulder, it is more worse condition. If it is unilateral, it is less worse. Okay? What are the risk factors for shoulder dystocia? Something related to the mother, maternal, and fetal causes, and causes related to labor itself. Causes related to the mother include gestational diabetes, post-maturity, abnormal pelvic anatomy, contracted pelvis, or abnormal shaped pelvis, and short stature and obese mother. What about the fetal causes? Fetal causes, the macrosomic baby. And the macrosomic baby caused by either constitutional or due to gestational diabetes or diabetes pregnancy, or due to excessive weight gain during pregnancy, or excessive nutrition during pregnancy, or obesity, or family previous obstetric history of the same condition, or family history of similar condition. So there is previous, in the same case, previous history of shoulder dystocia, or previous history of delivery of macrosomic baby, or previous history of difficult delivery. Okay? Lastly, risk factor related to the labor itself. What is the risk factor related to labor? Mid-pelvis forceps or vacuum extraction. This is the risk factor related to the labor itself. Mid-pelvic forceps delivery or vacuum extraction. Okay. Could it be predicted, shoulder dystocia? Is it predicted? Yes, you can predict it by taking history of complication, previous obstetric history of delivery of macrosomic baby, difficult delivery, shoulder dystocia in the previous pregnancy, very important. History of diabetes mellitus, especially if she wasn't controlled before pregnancy. Okay, so this is important as regard the history. During your antenatal care, you measure the body weight, body mass index, it's important, and you measure the fetal diameters, the biparietal diameter, femur length, abdominal circumference, the expected fetal weight, and you could predict this or diagnose the macrosomically. Okay? And of course, you should control diabetes during antenatal care if the patient is diabetic. Okay. Anything preconception, and you should counsel your patient before being pregnant? Yes. You should counsel her if she is obese to reduce her body weight, or if she is diabetic to control her diabetes before being pregnant. This is very important. Let us go to a case coming to us in emergency department in labor, and after delivery of the head, we was surprised by shoulder distortion. Like this case, the head emerged through the introitus, then retracted over the perineum like that. What is called turtle sign. Yes. So, what are the maneuvers needed to be done to deliver such fetus? I have a problem now. What is the problem? The problem is this shoulder, the anterior shoulder, either widget behind the symphysis or overriding the symphysis pubis like that. This is the problem. So it is bony impaction, as you see here. It is bony impaction. So this is the problem. It is not a soft tissue obstruction, it is bony obstruction or bony impaction between upper pubic ramus and the shoulder, the anterior shoulder. Okay? Okay. What is the steps I wanted to do to deliver the shoulder and manage such situation? Okay. First, do macroberto position. What is macroberto position? I will do flexion. My assistant know very well this maneuver. Each one will flex the leg towards the abdomen of the mother. Extreme flexion of the side to the abdomen. Okay? And the abduction also. Like this picture. Can you see this picture? This is the assistant. Do flexion to the side towards the abdomen of the pregnant lady. Okay? Why I'm doing this step, macroberto position? I'm doing it aiming for what? Flattening of the sacrum and flattening of lumbar lordosis. So give more space for the pelvic inlet. Also, the rotation of the symphysis kephalat. So symphysis rotate kephalat and sacrum pass backward, what's called flattening of the sacrum and the lumbar lordosis. So the surface area of the pelvic inlet will increase. This increase will help the anterior shoulder to be slivered under the symphysis and the delivery. So macroberto position itself can cause delivery of the shoulder in up to 40 or more of cases of shoulder distortion. Another step I can add to macroberto position, doing suprapubic pressure. How can I do it? Like cardiopulmonary resuscitation. All of you know it. I hold my hand like that in the suprapubic area on the anterior shoulder, in which surface the anterior, this is the anterior shoulder, this is the posterior surface, this is the anterior surface. I wanted to push on the posterior surface and direct it downward and laterally like that. So this is the fetus. I'm going to do pressure like that. Can you help me please? Like cardiopulmonary resuscitation in the suprapubic area. I'm now on the anterior shoulder. I'll do pressure downward and laterally. Downward and laterally. Okay. Downward and laterally. What is my aim? My aim is to decrease the base acromial diameter. This is when I did this pressure. Sorry. Can you hold it please? When I did pressure down and laterally, this acromial diameter decreased. So the anterior shoulder will slipper under the symphysis pubis to the cavity to the outer. Okay? So this is my aim, to do adduction of both shoulder, decreasing this acromial diameter, and so the shoulder will be delivered. This is called suprapubic pressure or Rubin 1 maneuver. Suprapubic pressure or Rubin 1. Okay. Suppose I did this McRobert position and I did suprapubic pressure, McRobert position and the suprapubic pressure, and failed. Both of them failed. I'm going to shift to Rubin 2 maneuver. What is Rubin 2 maneuver? I insert my finger, trying to push on the back of the anterior shoulder like that. Trying to push the shoulder towards the side of the chest like that. So, you can see here, hold that please. I am now inside the vagina. I'll shift and do pressure like that towards the side of the chest. Move it, please, like that. Okay? Why I'm doing this Rubin maneuver? If I change the plane where the shoulder in, maybe a bigger diameter reach it in the pelvis, so the head can deliver with gentle downward traction of the head. Okay? This is called Rubin 2 maneuver. Rubin 2 maneuver, like in this picture. This is Rubin 2 maneuver. Two finger in the back of the anterior shoulder, pushing it towards the side of the chest of the baby. Okay? Aiming for what? Moving the shoulder diameter, this acromial diameter, toward a different plane in the pelvic inlet, so the shoulder may slap down to the inlet and the cavity. Okay? If I did Rubin 2 maneuver and the fill, I'm going to do another maneuver called Wood corkscrew maneuver. Wood corkscrew maneuver. What is Wood corkscrew maneuver? I insert two fingers on the anterior surface, two fingers on the anterior surface of the posterior shoulder, like that. And another two fingers like Rubin maneuver. You remember Rubin maneuver when we said two fingers on the anterior shoulder, but in odds back and pushing towards the side of the chest? The other two fingers in Wood corkscrew will be on the anterior surface of the posterior shoulder, trying to move the shoulder girder like that, rotate it like that. While rotating it like that, the head may be slapped and delivered. The shoulder may be slapped inside the pelvic inlet and the cavity and the outlet and delivered. If not, I'll continue the rotation until reaching 180 degree. In 180 degree now rotation, the anterior shoulder become posterior and the posterior shoulder become anterior. So the pony impaction of the shoulder on the symphysis pubis now is not present. So again, corkscrew maneuver again. This is the head, okay? This is the anterior shoulder, this is the posterior shoulder. Two fingers on the posterior shoulder, but on its anterior surface. Two fingers like Rubin maneuver on the posterior surface of the anterior shoulder. Move the finger towards the chest, the side of the chest, like that. While the other finger on the posterior shoulder, moving it in the same direction till I move it 180 degree. Okay? The position was like that, become like that. This is 180 degree. Aiming for what? Aiming for changing of the plane of the shoulder girdle During this, do gentle downward traction. So I need assistance with me, of course. I need assistance for macro-rover position, for suprapubic pressure, for while doing this gentle downward traction of the head, and so on. If I did this and the delivery occurred, very nice, it's fine. If not, I'm going to do the next maneuver. What is the next maneuver? Again on the model, like that. I move it, like that, like that, like that, like that. Now, this is what screw maneuver. The anterior shoulder becomes posterior and the posterior shoulder becomes anterior. While that gentle downward traction. If the delivery occurs, it's okay. If not, and you reach 180 degrees, but still filled, I can do the reverse. What's called reverse corkscrew. Reverse in the other direction. If the baby was like that, and we did what's corkscrew maneuver. Sorry? Keep it in the same. So we did this rotation with corkscrew, 180. If filled, I can reverse the direction. Okay? Until the head gets a plane which can enter through the pelvic inlet and the cavity. If this maneuver failed, yes? You want to ask me something? I am changing the shoulder girdle. This shoulder girdle, I wanna, maybe if I rotated like that, it was like that. Maybe if I did rotation like that, little rotation, I'll go through another diameter of the pelvis. So shoulder girdle can enter through it. During all rotation, you keep rotation till reaching 180. At any step, if the delivery occurs, it's nice. If not, you reach 180 and stop, and again you can do reverse corkscrew. Okay. If filled, with the corkscrew and it's reverse, I have another choice, which is delivery of the posterior shoulder. Yes, delivery of the posterior shoulder. Remember something. I need somebody to register the duration of each step. Shouldn't exceed from 15 to 30 seconds. Each step shouldn't exceed from 15 to 30 seconds. So we are in emergency, very emergency situation. We should be in a hurry. Okay? Okay. Next step is to do, this is the head delivered, but the shoulder, there is dystocia. I wanna to deliver the measurement like that. Sorry, like that. The head is delivered here, and we wanted to deliver the posterior shoulder. What is the maneuver? Why I am trying to do delivery of the posterior shoulder? What is my aim? My aim is, if I can deliver the posterior shoulder, the space or the shoulder girdle will decrease. The base acromial diameter will decrease because one shoulder is out. So I'll try to bring one arm outside. Delivery of the posterior arm. Why I choose posterior arm? Because there is more roomy pelvis due to concavity of the sacrum, as you see here. So I'll try to get the arm, the posterior arm. Okay? Okay. How to get it? You will enter through the pelvis like that, then reach the cubital fossa, then do flexion to the arm. Then sweep in front of the chest, sweep the arm in front, the forearm in front of the chest like that until it is delivered outside. Okay? When I did that, the base acromial diameter will decrease, allowing the anterior shoulder to slap from behind the symphysis to the inlet cavity out. Okay? On the model, I'll try to deliver the posterior arm like that. This is the posterior arm. Can you see what will happen when we deliver the posterior arm? The anterior shoulder slip immediately because the diameter decreased now, like that, and the head and the baby is out. Okay, so bringing down or bringing out the posterior arm or delivery of the posterior arm will reduce this diameter and help in delivering shoulder dystocia. Okay. If I did this maneuver, I tried to this maneuver and I failed to deliver the posterior arm, what is the next step? Now I am in a very emergency situation. I have either first try conservative maneuver, which is called all fours position. Ask the pregnant lady to lie in all four position. Like what? By the way, I wanted to let you see before we go to all fours. This is how to deliver the posterior arm, as you see here. 2 finger inside, flexion at the cubital fossa, get the arm outside. This is delivery of the posterior arm. This picture show you the wood cork screw maneuver. As you see, 2 finger in the back of anterior shoulder, 2 finger in front of the posterior shoulder, and the rotate towards the side of the chest, up to reaching 180. I told you about it. So, this is step, then this is step. If I did both and failed, so up till now I did macrober position, flexion to the side towards the side of the abdomen, and suprapubic pressure. And we said more than 50% of cases can be delivered by just this maneuver. Failed, go to the next Rubin maneuver, which by 2 finger on the back of the anterior shoulder, I tried to do adduction, do pressure on the back of the anterior shoulder, will cause adduction and decrease of this acromial diameter, and also may change the plane of the shoulder in the pelvis. If Rubin 2 failed, I will go to do wood cork screw maneuver. If it is failed, I'm going to do posterior arm delivery. If it is failed, I'm going to try all four position. All four position like this picture. Aiming for what? This position was found to increase the pelvic surface area, so will help the shoulder to slap behind the symphysis toward the inlet and the cavity. So this position increases surface area of the pelvic inlet and may help me in this problem. And it is better to add something for all four position, is to do more flexion to the side towards the abdomen like macrober, but in this position like in this picture. The head towards the side of the floor, as you see, more flexion of the side toward the abdomen, and she is on all four also. What is the aim of here? I wanted to increase more the surface area of the pelvic inlet, because the symphysis pubis will be rotated kephalat, as we said before in macrober position, and the sacrum become more flattened and the lumbar lordosis become more flattened, so the anteroposterior diameter will increase. Okay? So the pelvic surface area of the inlet will increase. If I did this maneuver and it is filled, I have one of two choices. Either doing symphysiotomy by cutting the symphysis pubis, which is fibrocartilaginous joint here between the two pubic rami. I'll cut it after I insert Foley's caster, because I am afraid from injury of the bladder during this maneuver, and guided by my finger. I'll cut this symphysis pubis. Okay, so the two hip bone becomes separated, so the space become wider, the surface area of the inlet increase, the shoulder will descend immediately. This is called symphysiotomy, as in this picture. I'll cut here. This is the tubular mine. Symphysis pubis here. I'll cut in this area. I have here two ligaments, superior arcuate ligament, inferior arcuate ligament here. Here. This is the superior, this is the inferior, and this is the symphysis pubis. I'll cut here. Of course, this complication of this operation may be bladder injury, okay, or injury to the fetus, or maybe causing femoral neuropathy. This is called symphysiotomy, aiming of what? This is a catheter which is inserted to empty the bladder, aiming to increase the surface area of the abdomen. Okay, what is the other choice? The other choice, rather than symphysiotomy, is to do Zavanelli maneuver. What is Zavanelli maneuver? Under anesthesia, and give the patient muscle relaxant, cause relaxation of the smooth muscle like nitroglycerin, or general anesthesia like Flexion. Then you will do the reverse. The head delivered and did 1/8 circle rotation, so regain the head in occipital anterior, direct occipital anterior position. Then flex the head, because the head was delivered in extension. So and do the reverse, flexion of the head. Then push the head up, like that, inside the uterus. Then do cesarean section and delivery of the baby. You cannot do the Zavanelli maneuver if you, during the previous maneuver, the cord escaped outside and you did clamping and the cutting. You can't do it. Okay? So, you can't do that. Something very interesting. Now we finished the old maneuver. Neck rover position, suprapubic pressure, which is called the Rubin 1. Then Rubin 2 maneuver. Then Wood's cork screw maneuver. Then delivery with the posterior arm. All of these failed. I am going to do all 4 position. This is number 6 step. If failed, I have one of 2 choices. Either symphysiotomy or the Zavanelli maneuver. Okay? This one. I have one of these choices. Either symphysiotomy or the Zavanelli maneuver. The symphysiotomy, I'll cut here in the symphysis pubis. In the Zavanelli maneuver, I'll do the reverse of labor by rotation of the head, increase flexion, and pushing the head up inside the uterus. Then do cesarean section. Of course, it is not an easy job to do that. Rarely it is done nowadays. It's rarely done because it is difficult. Because all of us know one of the very special characters for the uterus is the contract and the retract. So the muscle decrease in size, length. The muscle decrease in length. So there is no more space. So it's not an easy job to get the head again inside the uterus. But of course, if you wanted to do it under relaxation. Give nitroglycerin or general anesthesia Flexion to cause muscle relaxation for the uterus to facilitate the getting the head out. Then do cesarean section. This is the last choice. I have another way of line of treatment. Was recorded as a case report in 1998 and was published in Obstetrics Gynecology journal by obstetrician known as Shagonisi, if I can read it like that, Shagonisi or Shagonisi. Okay? What he did was, in this situation, all the steps for shoulder dystocia failed. Then he tried to do abdominal surgery. He did laparotomy, then he did incision in the uterus like cesarean section. Then he didn't do delivery of cesarean section because he tried to do Zavanelli maneuver to put the head up, but he failed. So he is in a very emergency and a critical situation. He can't do, and he can't do symphysiotomy, so he is in a very critical situation. So you think about if he did laparotomy and open the uterus like cesarean, then you will do rotation through the incision in the uterus of the shoulder like that. Okay? The head will be slippered from overriding the symphysis or widget behind the symphysis will be changed. So he tried to do rotation simulating what's called Wood's corkscrew, but through the abdomen. He did it like that, then the anterior shoulder slivered and the baby was delivered. And the patient was gravida 6 gravida, fifth para, and the baby was, imagine the weight of the baby, 5.9 kilogram. 5.9 kilogram. So, of course, macrosomia, which is very difficult to be delivered vaginally. Okay, that's why shoulder dystocia happens in this case. Okay, what is the risk of shoulder dystocia and this maneuver? There is risk for the mother and the risk for the fetus. Risk for the mother, like what? What may happen to the mother? Maternal distress. Yes. Solution. Perineal laceration, vaginal laceration, cervical laceration, and even rupture uterus. Atonic uterus, yes, excellent. Atonic uterus. This prolonged maneuver and the manipulation may precipitate infection. Yes. Infection. Endometritis, postpartum infection, or infected wounds. Sorry? Postpartum hemorrhage, yes, because of mostly due to either traumatic or atomic. Possible. Okay? As regards the fetus, what's the problem with the fetus? What's the problem with the fetus? Some doctors, by the way, this head is out, he tried to stretch and downward traction the head. It is wrong. The head, when you are going to deliver the shoulder, must be gentle, slightly, mild, downward traction. Okay? Why? Because I may injure the brachial plexus here. Where is the brachial plexus? Between the neck and shoulder. Here. Okay? This brachial plexus, cervical 5, 6. Injury may cause Erb's palsy. Cervical 7, 8, thoracic 1 may cause another paresis or palsy called Klumpke palsy. So, cervical 5 and 6, if it is stretched, edematous, or confused, or teared of course is the most risky one, because just edema can resolve later on with physiotherapy, with time. But if there is a tear, yes, it could be permanent. So, this is as regards cervical 5 and 6, will cause Erb's palsy. This is the brachial plexus, and this is how it looks. This is the brachial plexus. This is the cervical roots, 5, 6, 7, 8, and thoracic 1. Okay? And I want you to see this one. This is the anatomy of the brachial plexus here. As you see, the area between the neck and the shoulder. So, how the baby can be injured? By stretching, by stretching on the head and by flexion. Hold it, please. So if I hold the head like that, I do downward traction, so I give some force for traction. Or I did flexion of the head like that, tilting it. Okay? Like that. Downward traction or tilting. Both this movement can injure the brachial plexus. Where is the brachial plexus? Here. In the neck, here, between the shoulder and neck. Okay. What is the picture of herpes pulse? Or herpes paresis? Or Duchenne paresis? You know, we call it waiter, tip side, waiter tip. You know how it looks? Like that. This is water tip, like that. Why it happened like that? There is relaxation with the flexors, paresis of the flexors, okay? There is clenching of the finger, like that. There is adduction, like that, okay? Because the injured is cervical 5 and 6. So they call it as water tips. If you are sitting in the cafe and you want to give tips to the waiter, you will take it like that, you put the money here. So they call it water tips. Okay? So, this is for herpes. What about the other palsy which you call Plombicky? Plombicky palsy. Plombicky palsy, the injured is cervical 7, 8 or thoracic 1. How it looks? How it looks? Anybody know? Plombick's palsy. Plombick's palsy? Anybody know about it? How it looks? I don't know if I have a picture here. Let us see myself. Plombick's palsy, there is paralysis of the smooth muscle of the hand and the rest. So there is foot drop. You can't flex. If you try to do grasp reflex, like that, you know, after delivery, the neonatologist can do some reflexes for the baby. Like grasp reflex. When I put finger, the baby will grasp it. This is reflex is lost. So there is rest drop, there is absent of the grasp reflex. This is called Plombicky palsy. Okay. Anything else? Yes. Maybe fracture humerus, maybe fracture clavicle. Okay. Dislocation of the shoulder. Excellent. All these fetal injuries. And it's very important. Okay? So we try to minimize this injury as much as we can. This is our rule. In case of shoulder dystocia, try to keep the mother safe and the fetus safe. Okay? So we should do the steps as I said, and they take a very short time, 15 to 30 seconds for each step, to reach the last step, which was the Vanelli maneuver or symphysiotomy, as I said before, and I told you about the case report before. There is still one line of treatment I didn't tell you about it because it is destructive one, injurious one, which is fracture of the clavicle. I intentionally do fracture to the clavicle. Why? The clavicle is here, this clavicle. I push it upward like that, trying to do fracture clavicle in the middle. Why I'm going to do fracture clavicle? as a management for a case of shoulder dystocia when all maneuvers fail and I reach the last step. In spite of doing symphysiotomy or the Vanelli maneuver, because it is difficult, I may do cleidotomy. It's called the cleidotomy. Fracture clavicle is called the cleidotomy. Okay? Like this one. This is the fracture in the middle. You can see it. Okay? This is fracture callus. This is complete fracture. I push with my finger upward. The clavicle is weak in the middle part to avoid injury of nearby vessels and nerves. Okay? Aiming for what? To decrease the bisacromial diameter. When one clavicle is fractured like that, the bisacromial diameter will decrease and shoulder will slap inside the gap. Okay? But of course this is invasive maneuver, aggressive maneuver. Okay? I should keep it for the end if I need it. Or if the baby is dead, already dead, I'm going to do it. No problem. Okay? Fortunately, the clavicle healing is rapid. So, as regards the resolving of the condition of this fracture, it is rapid. Okay? This is the end of my lecture today. Lastly, I summarize that shoulder dystocia is one of the most important obstetric emergencies because it affected the mother and the fetus and may cause maternal morbidity and mortality, and may cause fetal morbidity and mortality. How it can cause maternal mortality? Due to ruptured uterus, maternal hemorrhage, baby shocked and dead. So, yes, it is important. Also, it may carry a risk for the fetus and the many birth injuries, as we said, brachial plexus injuries, one of them, the fractured humerus, fractured clavicle, and shoulder dislocation. So, okay. It constitutes how many? The incidence of shoulder dystocia constitute about from 0.6 up to 1.5% for babies weighing 2.5 up to 4 kilograms. This is the incidence. So the incidence range between 0.6 up to 1.5. But this for babies with average weight between 2.5 kilogram to 4 kilogram. However, you expect the incidence to increase if the baby is more than 4, right? And if 4.5 will be more than 4 kilogram. And if the baby is 5 kilogram will be the incidence of shoulder dystocia increasing, right? So the incidence can reach in cases with baby weight 4.5 up to 5 kilogram, reach up to from 5 to 9%. Much higher incidence because of increase in the baby weight, which is a macrosomic baby. So the incidence is variable. Is the baby with a normal weight age, weight average, or not? If a macrosomic baby, the incidence of shoulder dystocia, of course, is more. However, shoulder dystocia can occur in average weight baby also. Okay? And we mentioned all risk factors, and we mentioned how to predict a case of shoulder dystocia and how to manage a case with shoulder dystocia and what are the maternal and the fetal hazard. This is the end of my lecture today. Thank you. And if you wanted to ask me any question, I'm ready to answer. Okay, thank you.